Welcome to Lung Point of Care Ultrasound, Module 4, Identifying Pathology. The objectives for Module 4 include identifying pulmonary edema, pneumonia, and pneumothorax. When assessing the dyspneic patient's lungs with point of care ultrasound, there are three key findings that suggest either pulmonary edema, pneumonia, or pneumothorax as the source. These abnormal findings include B-lines, lung consolidation, and absent lung sliding. The dyspneic patient without at least one of these findings should be evaluated for other pathologies such as asthma, COPD, pulmonary embolus, or non-pulmonary disorders. If one remembers from Module 3, the lungs are repeatedly divided until the smallest compartment of functionally complete lung tissue is reached, called the secondary pulmonary lobules. The secondary pulmonary lobules are bordered and separated from each other by the interlobular septa, which normally cannot be seen with ultrasonography. However, certain conditions thicken or widen the interlobular septa, causing them to fall within ultrasound's resolution. When this occurs, artifacts known as B-lines, or comet's tails, are produced. B-lines appear as discrete, hyperechoic vertical lines that originate from the pleura and never above it. In addition, B-lines extend into the peripheral fields of the ultrasound's monitor, move with lung sliding, and may erase A-lines in their path. With B-lines, the pleura, ribs, and rib shadows still exist, forming the bat sign. If you look over here on this picture, you can see the pleura is still here. You got a rib, and a little bit of a rib shadow, and rib shadow. And from the pleura extend these discrete, hyperechoic vertical lines. And you can see they're not forming above the pleura, so you know these are B-lines. And they extend, as you can see, these B-lines actually extend all the way down into the periphery. And then when you look for that bat sign, you can see that the bat sign is still there. And then these B-lines occur when the interlobular septa are thickened or widened, such as in pulmonary edema. There are several pathologies that widen the interlobular septa and produce B-lines. The two that we're most concerned with include pulmonary edema through increased hydrostatic pressure and pneumonia due to an increase in capillary permeability. B-lines can be unilateral, found in only one pneumothorax, or bilateral, found in both hemothoraces. For our purposes, pneumonia is typically unilateral, while pulmonary edema is bilateral, though it is true that pneumonia can be bilateral if the pneumonia is severe enough. It is important to note that gravity-dependent fluid can widen the interlobular septa at the lung bases and cause isolated B-lines to appear, but they're not pathological. For B-lines to indicate pathology, 3 or more must be present in a single intercostal space. Though you won't be tested over this material, it is important to know that B-lines are sometimes confused with two other types of lines, E as in elephant and Z as in zebra lines. Understanding the difference between the three is important. Unlike B-lines, E-lines do not originate from the pleura. Instead, they stem from the subcutaneous tissue above it. E-lines are formed when air trapped in the subcutaneous tissue, such as in subcutaneous emphysema, scatter the ultrasonic waves of POCUS. The scattering of sound waves creates hyperechoic, usually well-defined vertical lines whose movements do not coincide with respiratory or lung sliding. When E-lines are present, all landmarks below the subcutaneous air are obscured, including the pleural line, ribs, and rib shadows. In other words, the bat sign is no longer there. In addition, lung sliding and A-lines are usually gone. Like B-lines, Z-lines arise from the pleura, but have the following differences. Z-lines weaken after 2 to 4 centimeters and do not extend to the bottom of the POCUS monitor. Z-lines are not as distinct as B-lines and look more like a mass or a bundle of lines leaving the pleura. Z lines are not synchronous with breathing or lung sliding, and they do not erase A lines. Z lines have no significant pathological meaning and are found in healthy individuals. And here's a little chart that kind of lists the difference between B lines, E lines, and Z lines. And though you won't be tested over this material, it is, I think, kind of important to know the difference between these three lines so that appropriate diagnosis can be made. So now that we talked about B lines, we're going to discuss consolidation of the lungs. Normally, the alveoli of healthy lungs are filled with air, which scatters ultrasonic waves and prevents visualization of the lung's parenchyma. However, when the alveoli are filled with fluid or become collapsed, as with pneumonia and atelectasis respectively, they are said to be consolidated. Consolidated lung tissue propagates or transmits sound waves and thereby brings the texture of the lung's parenchyma into view. When the lung's parenchyma becomes well defined through consolidation, its echogenicity is like that of the liver and is referred to as hepatization. When the lungs are hepaticized, it indicates pathology, though not a specific disease, because several disorders can cause lung consolidation. If you look over here on the image, you can see that this is the pleural line, ultrasound probe sitting right up here. And we're looking down, and you see that this is the liver, and then we got the diaphragm. And then you can see this is lung tissue that's consolidated or hepaticized. And you can actually see little pleural effusions beginning. Now that we talked about B lines and lung consolidation, we'll discuss the last key finding, absent lung sliding. Lung sliding, if you remember, is the shimmering rhythmic movement of the viscera pleura as it glides against the parietal pleura during normal respiration. Lung sliding should always be present, and its absence indicates some form of abnormality between the parietal and visceral pleura. Sometimes lung sliding can be difficult to detect, and when that happens, we use M mode, which can verify the presence of lung sliding or the absence of it. If lung sliding is present, M mode will produce the seashore sign. If lung sliding is absent, M mode will produce the barcode sign. So let's look over here real quick. You can see this is B mode, and you can see there's the pleural line, and this shimmering rhythmic movement down here is called lung sliding. Looking over here on M mode, we see the seashore sign. You can see the chest wall, pleural line, and the rhythmic movement of the visceral pleura moving back and forth produces this sandy looking beach. Now looking over here on this picture, you can see that there's not really a whole lot of shining, shimmering movement in the tissue below the pleural line. And this we would call absent lung sliding. And we flip on the M mode to verify, make sure that there is absent lung sliding, and we look over here, we see the chest wall, we see the pleural line, and you see where there should be a sandy beach from the visceral pleura moving back and forth. We see just an absence of lung sliding. It's just a barcode looking thing because the visceral pleura is no longer sliding back and forth. Possible causes of absent lung sliding include pneumothorax, pleurodesis, infection, inflammation, pulmonary fibrosis, certain types of atelectasis, mucus plugging, pneumectomy, apnea, and a main stem intubation. So now that we've discussed B lines, lung consolidation, and absent lung sliding, let's see how they're used to help diagnose pulmonary edema, pneumonia, and pneumothorax. Pulmonary edema is a common source of dyspnea, and it has cardiogenic and non-cardiogenic origins. In pulmonary edema, the alveoli, interstitial, and pleural spaces fill with fluid, resulting in impaired gas exchange. Flooding of the lungs widens the interlobular septa, causing them to fall within the resolution of ultrasound, which creates B lines. Pulmonary edema does not interfere with normal lung sliding unless a large pleural effusion exists, nor does it cause lung consolidation. So over here at this moving image, we can see that there's a pleural line. There's a rib with rib shadows. And we can see the bat sign is intact. And looking at these hyperechoic vertical lines, we see that they're not above the pleura. They do extend all the way into the periphery. There is more than 3 per intercostal space, and they move with lung sliding. So you can tell just by those that these are B lines, which suggest fluid in the region or fluid in the lungs. And so they're very suggestive of pulmonary edema. Taken in concert with the patient's history and clinical presentation, pulmonary edema can be diagnosed with POCUS when the following findings are present: diffused bilateral B lines, usually 3 or more B lines per intercostal space, and usually in more than one viewing zone bilaterally or in both hemithoraces. Normal lung sliding in the absence of a major pleural effusion, and no lung consolidation. It is possible to also have pleural effusions, and that's what this image over here is showing. It's actually just showing a pleural effusion. That's what I wanted to show you all. So you can see this is the liver, and this is the lung tissue. It's kind of showing up here every once in a while, but this black fluid, this is all fluid, and this is a pleural effusion. Another frequent source of dyspnea is pneumonia. Pneumonia is a lung infection caused by a viral, bacterial, fungal, or chemical irritant. With pneumonia, the infected region experiences an increase in capillary permeability, leading to localized edema. The edema distends the interlobular septa, creating unilateral B lines. In addition, the edema and infectious process fills the alveoli with fluid, pus, and other biological debris, impairing gas exchange and leading to lung consolidation. As the infectious process reaches the pleural line, which it almost always does, it interferes with normal lung sliding. Therefore, taken in consideration with the patient's history and clinical presentation, the diagnosis of pneumonia using POCUS can be made when all 3 abnormal findings are present: the B lines, lung consolidation, and absent lung sliding. There are 3 additional signs that may or may not be present in the pneumonic patient, and they include the shred sign, dynamic air bronchiograms, and irregular pleural line thickening. The shred sign may occur when consolidation from pneumonia affects only part of a lung lobe. A jagged, shredded edge appears at the interface between consolidated tissue and partially aerated alveoli. Dynamic air bronchiograms are bubbles trapped within the bronchioles of the consolidated lung tissue. They appear as hyperechoic, point-like particles that move centrally or away from the transducer during inspiration. When present, the mobile, hyperechoic air bubbles are 100% specific for pneumonia. An irregular pleural line thickening occurs when the infection reaches the visceral pleura, which happens in most pneumonia cases. The inflammatory and infectious process causes the pleural line to thicken and take on an irregular shape, which disrupts normal lung sliding and causes pleuritic pain. Looking over here at this top image, we'll go through it real quick. You can see at the top there's absent lung sliding, and there's no real well-defined pleural line. It's kind of there, and that would be an irregular pleural line. This here is lung consolidation, and inside the consolidation you can see these little point-like hyperechoic bubbles moving centrally during inspiration. So those are dynamic air bronchiograms, which are 100% specific for pneumonia. Moving a little further down, you got this jagged, rough edge. This would be the shred sign between consolidated tissue and partially aerated alveoli. Finally, in the partially aerated alveoli, you see these B lines. So this is a classic case using POCUS of pneumonia. This next image down here, you can see even more so an irregular pleural line thickening. Lung consolidation. Inside the consolidation are these dynamic air bronchiograms. And a little further down, there's some more aerated tissue. I don't specifically see a jagged or the shred sign. But anyways, this is another example of pneumonia, these dynamic air bronchograms being 100% specific for it. Just like pulmonary edema and pneumonia, a pneumothorax can trigger dyspnea. A pneumothorax usually occurs suddenly when gas or air enters the pleural space, the area between the parietal and visceral pleura, causing partial or complete collapse of the affected lung. There are multiple etiologies that can contribute to the development of a pneumothorax, including COPD, cystic fibrosis, malignancies, infections, and traumas. In addition, pneumothoraces can occur spontaneously. A pneumothorax can be diagnosed with a thorough POCUS exam, taken in consideration with the patient's history and clinical presentation. There are two expected findings of a pneumothorax when using POCUS: absent lung sliding and lung point. Absent lung sliding is always pathological, and a pneumothorax should be near the top of your differential list. Yet, absent lung sliding does not specifically indicate pneumothorax, since other pathologies can present with that finding. However, the presence of lung sliding rules out a pneumothorax at the site of examination with 100% specificity. Lung point is a dynamic sign that is 100% specific for pneumothorax. Lung point is seen at the junction or edge between sliding and non-sliding lung tissue. It occurs when normally aerated lung tissue slides into view of an area with absent lung sliding and represents healthy lungs moving into view of an area with a pneumothorax. And looking over here at the picture, you can see this is the chest wall, the pleural line, and this region right here, there's no shining, shimmering motion, so there's really no lung sliding going on. But then you see this section over here, it's kind of shining, shimmering, and moving into view, and there's this defined point. This is called lung point. And this is 100% specific for a pneumothorax. Module 4 Summary. B lines are discrete, hyperechoic, vertical lines that originate from the pleura, extend into the peripheral fields, move with lung sliding, and may erase A lines. Typically, unilateral B lines suggest pneumonia, while bilateral B lines suggest pulmonary edema. Healthy lungs are filled with air, which scatters ultrasonic waves and prevents visualization of the lung's parenchyma. When the alveoli fill with fluid, as in pneumonia, they become consolidated. Consolidated lung tissue transmits sound waves and thereby brings the texture of the lung's parenchyma into view. When the lung's parenchyma becomes well defined through consolidation, its echogenicity is like that of the liver's and is referred to as hepatization. Lung point is a dynamic sign that is 100% specific for a pneumothorax. And here are my Module 4 references. Thank you again for taking your time to help me complete this DMP project. Please continue on to the Module 4 post-test. And we would love to see you at the Interactive Skills Workshop going to be hosted at Southern Adventist University. We'll have an ER physician trained in POCUS walk you through a lung point-of-care ultrasound exam. And to do that, to sign up for a time, just go to the website's menu bar, click on ISW Scheduling, and set up a time to come join us. Come practice. If you'd like more resources, more information on point-of-care ultrasound, click on the website menu bar's resource tab, and I've got some additional information there if you're interested. All right, thank you. See you soon.